It's just difficult to be will probably join.
Yeah, I don't mind people walking into the classroom. I really don't mind that. But I'm just conscious I've now got less time to present. Are you happy if I crack on?
Yeah.
Hello, my name is James Bennett. I'm a consultant anaesthetist and I'm the lead consultant lead for acute pain. I'm mainly based at the Conquest. I've been asked to present a lecture today, which is normally about 60 minutes on prescribing pain relief. This was me when I qualified. I felt that, reflecting on my time at medical school, I felt that pain was taught very badly. And when I turned up on the wards on my first day, I really didn't have a good understanding of pain relief. So I don't think this was just me. I think it was actually a national and a global problem. So about a decade ago, a couple of anaesthetists from Australia and New Zealand created a bunch of lectures teaching pain, which was actually originally aimed for nursing staff and doctors in developing countries. Actually, they then incorporated into their medical school training, and this is actually endorsed by the Faculty of Pain Medicine. So my slides in the next hour are supported by the Royal College of Anaesthetists and the Faculty of Pain Medicine. So the overall aim of this lecture is to try and recognise pain better, try and assess pain better, and try and treat pain better. Now, I'd like to say from the start, this is acute pain rather than a lot of chronic pain. And I will not be going through every single drug in a lot of detail. I just haven't got the time to do that. It won't be a journey through the BNF, okay? So for any good course, you need a good acronym. So with BLS, ALS, you've got ABC, airway, breathing, circulation. I'd like to introduce to you the acronym RAT, R-A-T, recognise, assess and treat. So what we'll do first of all is start with recognise, and within recognise we need a good pain definition, and we'll discuss the benefits of treating pain. So the International Association of the Study of Pain created a definition of pain way back in 1979. More recently, this was revised, and in 2020, we now have a definition that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. It's not snappy by any stretch of the imagination. But essentially, the three main things to get across is that it's unpleasant. There may be a physical aspect, but there may be a psychological aspect. There may be an injury. There may not be an obvious injury, okay, but the patient may still have pain. So another definition, which was done by Margot McCaffrey, who was a nurse in 1968, she put forward the definition: pain is whatever the experiencing person says it is, existing whenever they say it does. So pain is not always obvious, but it's always important to believe the patient. Okay. So we talked about unpleasant nature, emotions are important, and the cause is not always visible. You should always believe your patient. And that should trigger you thinking about how you're going to start managing their pain, or how can you improve their pain. So now we've done a definition in our heads, got a definition in our heads. What I normally do, but because we're pushed for time, I normally ask you guys, what are the benefits of treating pain? There are four main categories. There's benefits for the patient, there's benefits for the family, there's benefits for society, and there's benefits for the hospital. We'll only discuss the patient. Why is it important to treat pain for a patient? Pain normally gets better, doesn't it? Any idea?
Stop them doing things. Stop their healing.
It certainly can stop them engaging with staff or physiotherapy. Yeah, if they're in pain, they won't They may not feel valued, they may not want to engage with multidisciplinary specialities.
It's similar, it's muscle pain or something, and they've got to do certain exercises, or like with respiratory stuff, and then like breathing.
Yeah, great. So rib fractures, for example, if you don't treat them, they're likely to not be able to breathe effectively, they can retain secretions, and they can get chest infections. Same with abdominal pain. If you've got really severe abdominal pain, you won't breathe effectively, and you can get chest infection. Moving around in the bed as well, if you've got really, really bad pain, you're going to sort of keep quite still, and you can get DVTs and PEs and pressure sores. If you've got coronary artery disease, if pain is causing your heart rate to go up, your blood pressure to go up, that will put more stress on the heart. So obviously there's a humanitarian aspect to treating pain. Patients sleep better, they can eat and drink, and if you treat acute pain effectively, it's less likely to develop into chronic pain, which has a huge healthcare cost. That patient may play an important role in their family. They may be the sole carer for their parents or spouse. For society, if that patient can get back to work, they can start paying their taxes again, or if they have an important job in the community, they can do that. And for the hospital, if pain is treated effectively, they should theoretically have a shorter hospital stay, less bed costs, less likely to need social care. Patient satisfaction is important, and friends and family surveys are important for the hospital to generate extra income. So an added thing with regards to recognise, if you feel that you're dealing with a patient that's in pain, you need to double check that their relatives know that patient is in pain, the nursing staff know, and do your seniors know? And also, do you need any extra help? Do you need anaesthetists? Do you need the acute pain team to review the patient? Just in summary, we've talked about definition. Pain can be very subjective. Treating pain is important, and who else needs to know about this, and do you need any extra help? So that's R of rat. Let's move on to A, which is assessment. Important things to consider with assessment of pain. We need to know what the severity of the pain is. We do need to tease out what type of pain it is, and is there anything else affecting that patient's pain? Is there anything that's making the pain worse for the patient? You do need to go to see the patient and ask them questions. Why do you think we need to assess severity? So, once you establish the severity of pain, it will guide you what treatments will be necessary for this patient. So if a patient is in severe pain, you're not going to give them just paracetamol. And the converse, if they've got mild pain, you're not going to give them fentanyl patches or Longtec. There's this concept of pain as the fifth vital sign. So this stems from America back in the 1990s, and the American Society of Pain did a study and found out that about 45% of inpatients in American hospitals at some point were in excruciating pain. So that's quite a high number. So what they tried to drive was, ask patients whether they're in pain, assess their pain. The problem is, the more patients you ask, the more likely they're going to tell you they've got a high pain score. And in Florida, I think it was, there was a 150% rise in opioid prescription consumption. So there has to be a balance between asking the right questions, but be mindful what reaction or action you should take. But it is important to measure and record severity. But it's not about asking the question when the patient is completely still in the bed. You don't want a patient to be in pain, and the only way of relieving the pain is for the patient not to move. You need a dynamic pain score, so taking the pain assessment both at rest and on movement. So it's called a dynamic pain score. Even more important than that is this concept of a functional pain assessment. Now, I just want to say, first of all, that there is no validated score for assessing the pain from a functional perspective. But the question you need to ask yourself, what is that pain stopping the patient doing? So we're going back to effective breathing. If a patient has had surgery on their abdomen, if they can take a deep breath in, if they can eat, if they can drink, and if they are mobilising okay with a physio, and they're sleeping okay. From my point of view, even if the patient says that they're in 9 out of 10, 10 out of 10 pain, based on their functional ability, I would be reserved on prescribing strong opioids, even though their pain score is high. I'll come along a little bit, I'll come back to opioids, but that doesn't mean you don't do anything. You're still empathetic, you're still warm, there's still other medications you prescribe. But if they're able to mobilise outside with a drip stand and smoke, their pain control is reasonable. Okay, so we've talked about the problem with a fifth vital sign. We've talked about the problem of the fact that it's a very subjective perspective, doing a pain score and getting just what the patient says. You can't take it in isolation. You need to know their functional status, psychosocial influences. They don't assess sedation either. So just one take-home message, a high subjective pain score doesn't mean you need to prescribe strong opioids. Also, with pain treatment, especially for a post-surgical patient who's just had an operation or on day one and you're reviewing them, the patient can't expect to be pain-free. The pain should be tolerable and they should be able to carry out their important daily functions, sleeping, eating, drinking, moving around in the bed. Think about dreams for function. So the acronym DREAMS: drinking, eating, mobilising and sleeping. If you rely solely on the pain score, you will prescribe more drugs at higher doses, and as you know, side effects are linear to dosage. So if you go up on the dose, you're more likely to get the unpleasant side effects. So you want to get a nice balance between patient comfort, functional recovery, which is eating, drinking, mobilising to the toilet, bladder and bowel, and you don't want them to have side effects like delirium, sedation, respiratory depression. So what methods are there for assessing pain? So there's a verbal rating scale, so you either use a number scale or you get them to say, is it mild, moderate or severe? But there's also a visual pain scale, which is essentially a 10 centimetre line, and you get that patient to mark on that line where their pain is, with 10 centimetres being the worst imaginable pain, 0 centimetres no pain at all. You put across, and the good thing about that is that you get a pain score at that moment, but also if you start giving them pain treatment, you want to see an improvement in that pain score, and you want to see the cross moving to the left. This isn't very practical. As I said yesterday, I don't carry around a 10 centimetre line in my pocket. It is quite useful for studies, experiments, drug trials, because as you can imagine, 10 centimetres equals 100 millimetres, and you can get a percentage, and then you can crunch some data. Basis scale is good for children, but I find it's useful for elderly, cognitive impairment patients, dementia, learning difficulty patients. So unfortunately, with this PowerPoint structure, I can't do my animations. Luckily, I haven't got too many, and they're a bit rubbish anyway. But what I want to, this next slide, is that we've all come across patients, elderly, who have got delirium, who are screaming, agitated, aggressive, wandering around, picking at things, fidgeting, just not engaging with staff. Quite often we do manage those patients with haloperidol or some kind of sedative, from a good point of view, to try and get them in a safe position, into their bed, into a chair. But quite often they may be acting that way because of pain. And so you need to have a think, is this patient in discomfort? Can we do anything about that? It's very difficult to assess a patient's pain if they've got dementia, especially if they're not able to talk to you, if they're non-communicative. So what we use in that situation is the Abbey Pain Scale. I don't know if you've heard of that scale. There are 6 categories in the assessment. Each category is out of 3, but there's 4 points, so 0, 1, 2, 3. and you add them all together, and if they've got a pain score above 8, they've got moderate pain. If they've got a pain score above 14, they've got severe pain. It's a validated pain scale, so what it allows you to do is be confident that to give someone who's not able to vocalise their pain to you, you can justify giving them strong opioids or strong painkillers when they're not able to tell you their pain. And the categories are things like whimpering, facial expressions, body language, behavioural changes like food refusal. You use observations as well, and also see physical changes like obvious injuries or pressure areas. The one thing, it's the best thing we have, and that's what we use in our trusts. But what I don't like about it is the subjective nature of it. So what's the difference between a mild grimace and a moderate grimace? What's the difference between moderate fidgeting and severe fidgeting? That's sort of what I'm trying to get at. But it is the best thing we have. So we've talked about severity and assessing how bad pain is. We need to work out what type of pain we're dealing with here, because not all treatments work on all types of pain. There is no perfect analgesic agent. So we're going to now classify types of pain. We're going to give examples of pain and understand that treatment depends on the pain type. So these are the important questions to ask. How long has the patient had pain? What is the cause and what is the mechanism of the pain? And this is the most important slide, I think, of my talk, to gather what type of pain we're dealing with. So how long do you have to have pain for before it transforms from acute pain to chronic pain? A bit longer than that. 3 months, yeah, 3 months. And in terms of the cause of pain, it's really simple in this essential pain management set of lectures. It's either cancer or it's not. And the mechanism is either physiological, normal, nociceptive pain, or it's neuropathic pain or pathological pain. Just touching on cancer briefly, the reason why cancer is important in terms of type of pain is because opioids are a very important group of analgesic drugs for cancer pain. Chronic non-cancer pain, opioids have got a very variable effect, and actually quite often they don't work at all. So cancer and opioids, they go together very well. And it's not just the cancer pain itself, there may be iatrogenic reasons for pain associated with cancer, like chemotherapy, cryotherapy, radiotherapy. The other thing to say about cancer pain, quite often it's progressive, quite often it gets worse, and quite often you need to keep increasing the dose of the opioids that you're giving. Whereas I'm an anaesthetist, I tend to deal with post-operative pain or trauma pain. Pain should get better as the inflammation subsides and the healing process continues and completes. Right. You look like you're falling asleep already, but I'm going to make sure you're going to fall asleep now, because we're going to do pain physiology and pain pathology, and it's really looking at that pain pathway. I'm not going to go into a lot of detail. I'm just going to give you a really rough outline that will support your decision-making process of what painkillers to prescribe, it will all make sense in a moment, and also highlight some key areas where how drugs work. So there are many factors that affect us, how much pain that we have when we sustain an injury. There are different steps in the pain pathway, and different treatments work on different parts of the pain pathway. Have you heard of the multimodal approach? So it's about using different drugs that work on different parts of the pain pathway. If you do that, those pain treatments tend to work synergistically together so that you're able to improve the quality of pain and reduce side effects. Because they're working synergistically together, you can use lower doses of a certain drug compared to using it in isolation. So because you're using less of a dose, going back to what I said before, dose and side effects are linear, you're less likely to get side effects at the doses that you're prescribing. So nociception is literally just the activation of the pain pathway. pain is perceived, is a perception, it's what you actually feel. And just because the pain pathway is activated doesn't necessarily mean you're gonna suffer a lot of pain. There are factors that influence how much pain that you have. I'm just going to go straight on and describe what they are. So certain cultures, certain religions, psychological factors like anger, anxiety, depression can all influence how much pain an individual is in. There's a lot of inter-individual variability. I can do a list with the same surgeon doing the same operation, and I do exactly the same anaesthetic technique, and the variety of pain afterwards is substantial. And it's all to do with the individual. Personality, catastrophizing personalities, pessimistic people. If that patient's got chronic illness, has got cancer, they may not be able to cope with a new type of acute pain. They may really need to get back and look after their children, and they need to go back and look after their husbands or wives. So they want to get out of hospital quicker. So pain is not going to be a big factor for them. They need to get home. Does that all make sense? Yeah. So let's start the pain pathway. So there's 4 steps to it, 4 important steps anyway, 4 anatomical regions. There's the periphery, there's the spinal cord, there's the brain, and then there's a modulation element to the pain pathway as well. And we'll look at each step now. So in the periphery, you get a stimulus, whether it's sort of heat, cold, chemical, physical, mechanical injury, and that causes cell damage. Stuff that's normally contained within the cell comes out into the interstitium. And mediators such as bradykinin, serotonin, ATP, hydrogen, substance P, histamine, serotonin, all these things, they can activate nociceptors, which are pain receptors. And if enough of them attach to nociceptors, pain receptors, you create an impulse, you create an action potential, and then you get this pain information going up 2 types of nerves, the C fibers and the A delta nerves. So those first nerves that get affected are called either first order nerves or primary afferents, and they're heading towards the spinal cord. Does that all make sense so far? In the periphery, that can be amplified. That process can be amplified by cyclooxygenase enzyme. It can be amplified by macrophages, secreting things like TNF-alpha, interleukins 1 and 6. And also the nerves themselves, so the C fibers can secrete mediators, and that's called neurogenic inflammation. And you can get something called peripheral sensitization, so it amplifies the pain signal. So that's the periphery so far. Have I lost anyone? Yeah, it's okay so far, isn't it? And once we get to the spinal cord, those nerves, so the cell bodies of those nerves are contained in the dorsal root ganglion, and then they actually synapse in the dorsal horn. And they actually synapse in things called rex laminae, and then they're numbered, Roman numerals. The important rex laminae are 1 and 2, because that's where the pain fibers synapse. It's like a relay station. At that point, pain is sort of interpreted. If it's not important, it sort of stays there and fizzles out. But if it is important, it will then be sent up to the brain. A few important things to say at this point. It looks complicated, but bear with me. There are only 4 important circles to look at. In the synaptic cleft, there are 2 important receptors. The excitatory mediator at the dorsal horn is called glutamate. Glutamate can bind to 2 receptors. In normal circumstances, so normal nociceptive circumstances, it preferentially binds to the AMPA receptor, and that's a normal pain signal. Where you have sustained long pain or really severe pain, you get more glutamate, the AMPA receptors are overwhelmed, and they preferentially then go to the NMDA receptor. And if this receptor is opened, you get a whole lot of calcium influx. The magnesium ion there is moved aside, So more glutamate is attached, and you get wind-up phenomena or central sensitization. So you get a far greater pain signal. So a bit like the amplification in the periphery, you can get amplification in the dorsal horn as well. So the two other circles, if you look at 5-HT-NA on the top right, can you see that there's a descending nerve that binds onto that? So that is the modulation bit, which I'm going to be talking about later. That's the fourth step. And if you look at that calcium channel on the presynaptic membrane, that's important for a drug called gabapentin. All right, that's where the gabapentin and pregabalin work. It's a calcium channel, and that's related to how much glutamate is released into the space in between. So if that's bound onto by gabapentin, less glutamate is secreted. Good. Do you know which analgesic drug binds to the NMDA receptor? Yeah. And it's probably where magnesium works as well. Magnesium is an analgesic agent, and I think it works there as well. So, where are we now? So, that's right. So, we've synapsed in the dorsal horn, and we've now got secondary afferents there. So, that's the second type of nerve, which goes onto the other side of the spinal cord, and it goes towards the brain, and the second relay station is the thalamus. Again, a bit like the dorsal horn, is this pain information important or not? If it is important, it goes to three main parts of the brain. The brain stem, that's the primitive part of the brain. So if you injure yourself, the brain stem tells you to take a deep breath in, to gasp, tells you to cry, tells your heart rate to go up, tells your blood pressure to go up. So very primitive. The cortex, somatosensory cortex, it sort of tells you where that pain is, and it also tells you, like, let's say you've injured your foot, it tells you to sit down, it tells you to remove your shoe and sock, to have a look at your foot, to give it a rub, you know, that type of that higher functioning part. The limbic system is more the emotional side of pain, so it's giving a story to the injury. So if you've already injured yourself before, and it caused you a whole load of trouble, and it affected your life, your limbic system will be firing off. Also, if you've injured your foot and you've got an important sport to do, or you've said that you're going to see someone, or go shopping, or look after children, the limbic part is going to be firing. All right, so it sort of adds a story to the pain. Pain perception occurs in the brain. There is also, in normal circumstances, an inhibitory element to the pain signal. So the pain signal can be inhibited from the brain down to both the dorsal horn in the spinal cord and to the periphery. And this is very much serotonin and noradrenaline fueled. And I showed you where it occurs in the dorsal horn. It's a bit like people in the army not realising that they've had their arm blown off and stuff. There's a big noradrenaline, adrenaline-fueled action to this descending pathway, so it's normally inhibitory. There's also interneurons in the dorsal horn that can be inhibitory as well, so they're GABA and glycine mediated, and also you've got your endogenous endorphins that can damp down pain signals as well. We've got one slide of neuropathic pain, okay? It's just too vast a subject to talk about. Essentially, it's a very difficult type of pain to treat. Opioids don't tend to work very well. It's a sensory dysfunction. There's a pathology of the nervous system, and you may have to think about other types of drugs that don't include opioid to treat it. How do patients normally describe their pain if it's neuropathic? Burning, yeah. Burning is a really strong one, but it could be anything. Pins and needles, cold, hot, tingly, ants under my skin. Yeah, it's really, really bizarre and very difficult to treat. And it serves no protective function. We've all sat through lectures describing how pain is actually quite helpful. You know, the swelling stops you using it, so there's heaving of an arm, so you stop you using it. There's no protective function for neuropathic pain. So nociception is not the same as pain. We've just discussed there are physical and psychological factors that influence how much pain a patient is in. and different treatments work on different parts of the nociceptive pathway, and that's why the multimodal approach improves the quality of pain relief and also reduces side effects. So 35 minutes in, we still haven't talked about treatment yet, and I'm going to say it again, I'm not going to be able to go through every single drug that we use in acute pain. Oops. So with regards to these lectures, treatment is divided into non-pharmacological and pharmacological. And what I tend to do is just ask you guys, do you know of any non-pharmacological treatments of pain that we can use easily in this hospital? I'm not talking about aromatherapy or anything like that. And if there's anything that I can use I use on my pain round that's non-pharmacological. Yes. And what's ICE normally part of an acronym of?
RICE, yeah.
Yeah, if you just say what the RICE stands for.
Rest, ICE, compression.
Yeah, do we use compression anymore? Not really, sometimes, but not really. So a medical student a few years ago said comfortable positioning. I think that's quite nice, so I use comfortable positioning now. What is probably the most common non-pharmacological intervention that we do for pain in our trust? Really important, whole specialities devoted to it. Yeah, I'll give you that. There is psychology does have an important effect. So things like counselling, massage, those explanation, education, that's really important. Empathy, very important non-pharmacological interventions. But what's the most common intervention in this trust? Surgery. Yeah, if I broke my bone, if I broke my hip, I don't really want aromatherapy or mindfulness. I want to get my hip fixed by a surgeon. Good. So let's just go through it now. So we tend to categorise it into physical and psychological. You touched upon psychological, reassurance, explanation, counselling, all that stuff. Physical, RICE, surgery, physiotherapy. We didn't mention massage, acupuncture. So what about pharmacological treatments? But let's discuss them and you shout out some answers. But I don't want types of drug. I don't want routes of drug. I want categories of drug. Okay, I don't want different names or trade names. What categories of drug do we have that are analgesic? Oh, sorry? Non-opioid. That is a category of drug. Yeah, I'm allowing you to go into that category. Yeah. Like paracetamol. NSAIDs. You can have non-opioids. What else can you have? Opioids. Yeah. Yes. Examples. Yes. Anti-amitriptyline. Do you know any others? Fluoxetine's the other main one that we use. That's an antidepressant. You have to shout out. Morphine. What is an opioid? You said it earlier. Ketamine. Yes. So steroids, magnesium, alpha-2 agonists, so clonidine, carbamazepine, local anaesthetics, gabapentinoids. Yeah, that's it. So actually, there's not many categories of drugs. You can sometimes get overwhelmed. I got overwhelmed with how many different types of opioids there are, like fentanyl and oxycodone and long tech and short tech and OxyContin and what these things do. They're actually just opioids. So yeah. So what they've done is that they've categorised it to simple, opioids and others. And under simple, you've got paracetamol, you've got anti-inflammatories. Who should we be cautious with anti-inflammatories? Which type of patient? Elderly. Yeah. So they can cause damage to the stomach lining. So anyone who's had GI bleeds before, or gastritis, what's the other one I'm trying to say? Ulcers, bleeds. That you shouldn't be using that on there. The other important one is renal impairment. Asthma, about 5% actually do generally get a wheeze with anti-inflammatories, but they tend to tell you if they've had it before. So opioids, again, we split it up into mild. I don't like this splitting, but mild and strong. So mild is your tramadols and your codeines, and your strong is your oxycodone, fentanyl, pethidine, and morphine. Others, the adjuncts. So you've got your antidepressants, your anticonvulsants, local anaesthetics, ketamine, clonidine, magnesium. Now, the reason why I want to talk to you about this category is because there are two situations in my practice where I would consider the adjuncts. They're not really drugs to give routinely to people. You have to have a think about it, talk to your seniors, talk to the acute pain team, and have a think. There's two circumstances where I use them if I'm doing an operation which is known to be really, really painful. So you could argue a total knee replacement, you could argue a laparotomy, emergency laparotomy, amputations. You consider these drugs. The other scenario is when I have a patient who has risk factors for post-operative pain or risk factors for increased opioid use afterwards. What patients tend to have greater pain after an operation? What risk factors do they have? So if I had 50 people and they're all going to have an appendix out, are there any individuals there that will probably have more pain afterwards than others? Older? No, age doesn't really, sort of, actually younger patients, young females tend to have greater pain scores after an operation. That's not me saying that, it's good evidence to suggest that, okay, to demonstrate that.
Patients with communication difficulties, so they can't express.
They tend to be suboptimally treated, but it doesn't necessarily mean they're going to have more pain. Their pain scores aren't. Yeah, I know what you're trying to say. That's a good point. Yeah, but children as well. Yes, if you've got chronic pain, you've got chronic back pain, arthritis, you're going to have more pain afterwards. If you've got chronic illness, COPD, heart failure, arthritis, you're going to have more pain afterwards. If you're already on an opioid, you're going to have more pain afterwards. So this is called individualized pain management. This is when I would think about either giving more opioids or more importantly, thinking about other drugs that I can use. For example, ketamine, nerve blocks. So young females, catastrophizing personalities, anxiety, depression, chronic stress, pre-existing pain, preoperative opioids, preoperative gabapentin, it's a big one. If they're on gabapentin or pregabalin, I'm worried. They're going to have a lot of pain afterwards. Chronic illnesses, addictive personalities doesn't necessarily mean they're going to have more pain afterwards, but they're probably going to want more opioid afterwards because of the nature of their personality. Okay, smokers, people who drink a lot of alcohol, recreational drug use. It's not a given. It's not black and white, but quite often they're the ones that are asking for more and more. Good. So we've talked about the anatomical aspects of the pain pathway. What we're going to do now, after talking about the treatments, let's put those treatments back into the pain pathway and see where they work. So in the periphery, things like rest, ice, compression, elevation, and surgery, they all work in the periphery. Anti-inflammatories reduce that chemical soup that I was talking to you about, those mediators, reduces the amount and concentration of that. And the action potential travelling through the peripheral nerves, the primary afferents, the C fibres and the alpha delta, local anaesthetics will block that transmission. In the spinal cord, things like acupuncture and massage work from a non-pharmacological point of view. Local anaesthetics again, either as an epidural or a spinal anaesthetic, they work here. Opioids, they work everywhere. They actually work periphery, brain, spinal cord, they do work everywhere. And ketamine, because of the NMDA receptor, and they're an antagonist, ketamine works really well here, and magnesium works really well here, and so do the gabapentinoids. So in the brain, psychological therapy works here, but it doesn't have to be high-end stuff. When I pre-assess a patient for an operation, I do go into a lot of detail about education, explaining what I'm going to do, reassuring them, a bit of warmth, a bit of empathy, mindfulness, managing their expectation and saying that they're probably going to be in pain afterwards, they're not going to be pain-free. Actually, I do think it benefits knowing what they're going to expect. Pharmacological treatments, paracetamol, we don't really know how it works, where it works, but we do think it works centrally. Amitriptyline, alpha-2 agonists, it will work here. So, in summary, there are non-pharmacological and pharmacological treatments. They all work at different parts of the pain pathway, and there are three main categories of drug: simple, opioids, and other or adjuncts. Pain medications. Are you aware of a way of knowing what drugs to give? You know, do you have is there such thing as a guide? Do you know of any guidance to when you would give what? What is that? Wow, how did you know that? That's amazing. Well done. Yeah, the WHO ladder. Now, there's some merits to it. So, for example, you don't give paracetamol just for severe pain, and you don't give a strong opioid just for mild pain. So there is some merit in the fact that you work your way up, and for moderate pain, you use both the simple and the weak opioids, and with severe pain, you go over to the strong opioids. The problem is, this was created in the 60s. It was based on cancer pain, so not chronic pain, not neuropathic pain. It was cancer pain, and also it was oral treatments as well. And as I said, neuropathic pain is not involved. And it doesn't mention anything about non-pharmacological therapy. So for a post-op patient, this mirrors it a little bit better. So you tend to have your severe pain earlier on in your recovery. So you start off with strong opioids, and then as the inflammation reduces and the healing process occurs, you can then drop down to codeine, and then eventually just paracetamol and anti-inflammatory. Problem is, for both step 2 and step 3, you're relying a lot on opioids. And I'm just going to spend a little bit of time here just saying to you that a weak opioid like codeine and tramadol, that doesn't mean that they're safe. That doesn't mean that they don't cause just as much side effects. So codeine is notorious for causing constipation. Tramadol is notorious for causing confusion, delirium, especially in the elderly. And if you look at the number of patients who have become opioid dependent, a lot of them have become opioid dependent, not getting fentanyl patches or oxycodone. It's from getting stuff like cocodamol or codeine over a long period of time and not having their drug charts reviewed and not reviewing it, and the GP not reviewing their prescription. So they're not safe. And I also don't like them because 1 out of 10 people can't metabolize codeine, 1 out of 10 people can't metabolize tramadol. So why you're just giving them a tablet that has no effect. And there's also this concept of opioid-induced hyperalgesia. So I will talk about that later. Are there any surgeons here? Okay, tough crowd. Okay, so when you do if you do surgery, or if you do your surgical block, from an anaesthetic point of view, instead of using the WHO ladder or the reverse WHO ladder, what we are trying to do is for each patient having the same, for a certain operation, look at the evidence to find what drugs work for that intervention or work for that procedure. And this website, so this group, Prospect, have done just that. They've trawled through lots and lots of papers, gathered a lot of evidence, and then have provided recommendations for certain operations. And it's found at their website, and it's part of the European Society of Regional Anaesthesia. So what do I mean by procedure-specific analgesia? For every single surgical patient, for every single one, you should consider those non-pharmacological interventions. So positioning, education and reassurance. Above that, all patients should be considered for paracetamol and anti-inflammatories. Considered, not given. So anti-inflammatories, not everyone can have anti-inflammatories. Above that is to utilise regional blocks, spinals, epidurals, nerve blocks, because that will reduce pain without the reliance of opioids. And it's only when those three things are considered do you think about opioids themselves. And then We've talked about this already. If the operation is really painful or the patient has risk factors, that's when you think of the adjunct analgesics. The problem with nerve blocks is that you can get a lot of motor block as well as pain relief. And that's not great for things like orthopedics, when you want to mobilise them, get their muscle strength up and discharge them. But there are more and more nerve blocks on the block that are motor sparing, and they just concentrate on pain relief. We talked about anatomical parts to the pain pathway. There's also functional parts to the pain pathway, and an even simpler view is that there are only three things to consider when you're thinking about pain relief. There's the source of pain, how that pain is transmitted to the brain, and how it's processed. So the source of pain, anti-inflammatories, local anaesthetics can reduce that. The transmission of pain, again, opioids, nerve blocks, gabapentinoids, ketamine, that's spinal cord. And then the processing of pain, education, explanation, reassurance, cognitive behavioural therapy, mindfulness, empathy. Okay, so instead of four, there's actually just three. So, as I said, not going to go through them all. I'm going to send, I think I've sent my slides to the person, and you've now got the doses and indications, contraindications for all the commonly prescribed drugs. I just want to finish on opioids. I've got 10 minutes, have I? This is the film, The Good, the Bad and the Ugly. And when I think of opioids, I think of this film. Because opioids are good. They're great for acute pain. They're great for cancer pain. We've got lots of different types of opioids. Opioids that we can use in a variety of different routes. So just because a patient, is not able to absorb, we can still use patches. We can still use them subcut. They're well understood. There's a good evidence base, and IV morphine is cheap as chips. Okay, so great. So opioids are great from that perspective. Unfortunately, as we know, they do have side effects, and you could categorise them into short and long-term side effects. So the short-term side effects, which I regard as bad, you get sedation, nausea and vomiting, constipation is a big one, respiratory depression. And if you keep giving opioids, that patient can become tolerant, so you need a higher dose to get the same effect. The ugly part of opioid, quite a lot of which is only just becoming apparent. I would say just in the last 5 years, we're really starting to understand very well the more long-term harmful effects of opioids. The dependence, the addiction is well known, but things like opioid-induced hyperalgesia, the opioids themselves are amplifying and sensitizing the pain pathway, so that you're actually needing more opioid to treat the opioids you're already on. So if someone has been on cocodamol for months or even years, they will experience pain far greater, far more pain after an operation than someone who's opioid naive in general. You can also obviously get fatal overdoses. Cancer biology, there was thought or hypothesis that opioids through immune modulation, there's an increased rate of cancer recurrence. Have you heard of that? So breast surgery, colorectal surgery, if you use a lot of morphine, a lot of oxycodone, there's a higher rate of recurrence, but the evidence isn't strong anymore. We've moved away from that now. Diversion, do you know what diversion is? So you have an operation, you're going to look pain afterwards, you get prescribed opioids, and you go home on those opioids. Lo and behold, a few days later, your surgical pain is better, but you haven't completed the course of opioids that you're on, and you've got a whole stash of opioid in your household. So instead of throwing it away, you put it in the cupboard, and then a relative, friend comes around your house, complaining of a headache, and you give them some tramadol, you give them some Longtec. That's what diversion is, and that's what we're trying to clamp down on. You need to educate patients about the safe disposal of opioids. They basically need to go to their pharmacist. If you want to dive in a little bit into a bit more detail about opioids, there's this Opioid Aware campaign that's endorsed by the Faculty of Pain Medicine and the Royal College of Anaesthetists. Essentially, it was a group of people, group of experts, pain specialists, who have recommended how to use opioids and the problems associated with them. And these are the 5 main points. Opioids have limited use in chronic non-cancer pain. So for back pain, chronic back pain, opioids aren't great at that. If you are going to start an opioid, you should use it at the lowest effective dose and then titrate up after reassessment. If your patient is on an all equivalent of morphine above 120 milligrams, if you go above that, it's likely that the opioid will not have any effect and you're likely to cause harm to the patient. It's 120 milligrams in this country, in Canada it's about 80 milligrams. So it's a bit of an arbitrary figure, but certainly in my experience, if a patient is getting more than 80, I would say 80 milligrams is probably more accurate, you have to question whether opioids are actually working at all, and whether they're the best thing for this patient. If after a week's trial the opioid is not working, you should just stop them, even if there's no alternative. And opioid-resistant pain can be complicated by emotional influences. So that's from the Opioid Aware campaign. From my experience working in this trust and the acute pain team, this is something that I've added to this lecture. So the concept of opioid stewardship, we're in a very important position where we can prescribe opioids to our patients. So we are sort of the gatekeepers of starting patients on that journey of having opioids. So it's very important, and we need to be mindful and respect our responsibility. So do not aim for pain-free for any of your patients. Okay, it's just unachievable, especially when you're doing surgery. It's unachievable. They need to be able to tolerate their pain and to continue with their functional daily activities. Optimize things like paracetamol, optimize, if they can, anti-inflammatories, your non-pharmacological interventions. Weak opioids can cause just as much harm as strong opioids. I don't like cocodamol, I don't like combination therapies. If you're giving cocodamol 2 tablets 4 times a day, you're giving 60 milligrams of codeine 4 times a day. Codeine at 30 milligrams may just be as effective with less side effects. Slow release opioids like fentanyl patches and Longtec and OxyContin and Zomorph and MST, for acute pain, they're very difficult to titrate. And you find that they're very static things in the background. So you can have periods of time where you're in more pain than that drug is providing you, but also there is times where that drug is providing you too much pain relief and you get sedated. So it's not very in keeping with the acute pain pattern. Start low, go slow. Whenever you prescribe an opioid, make sure you prescribe the duration of action, duration of prescription, how long you want that course to last for. And remember about diversion, patient information leaflets, what they should be aware of in terms of side effects, how they're going to dispose of their opioids. So just in summary, pain can be treated safely and cheaply. Morphine is very effective for cancer and acute pain, but remember strong opioids should be avoided in chronic non-cancer pain, and they have their both short-term and long-term problems. 2 minutes, the RAT system. Think about recognise, assess and treat for any patient you go and see with pain. With assessment, how severe is the pain, what type of pain is it? Is there anything else influencing their pain that you can manage? And remember, there's non-pharmacological and pharmacological treatments. So an 86-year-old lady at home has fractured her right hip. There are no other obvious injuries and she has dementia. She has not complained about being in any pain. So what acronym can you use to manage pain in this patient? What acronym? RAT. So under recognise, is there anything important here to think about? So definition, yeah, likely to be in pain. Benefits of treating this lady's pain. Mobilising, yeah. She's going to be a sitting ductal pressure sore, DVT, PE. She might have some coronary artery disease. So yeah, pain is important, and obviously we're very nice people, you know, so there's a humanitarian aspect. So how would you assess this patient's pain?
Faces.
Yes, you could do. Yeah, could do. The faces scale is a very good way of assessing the pain. What if they're non-communicative? Commutative. Abbey pain score. Yeah. So you do the Abbey pain score and you think they've got severe pain. What treatments can you offer this patient? Yeah, really good. So remember, try and think about non-pharmacological and pharmacological. So non-pharmacological, what can you do for this patient? Surgery, fantastic. Yes, early surgery. Empathy, reassurance. You know, it's very scary for a patient with dementia in a new environment, hospital. So reassurance, explanation, probably talk to relatives as well. Rice, maybe, cold, you know, ice, maybe. Surgery is the most important non-pharmacological intervention. And what about pharmacological intervention? So we've talked about local anaesthetics. So fasciitis block, fantastic, brilliant. Anything else? What other categories of drug can we use? Simple, so paracetamol, anti-inflammatory is contraindicated. Opioid, how can we provide opioid to this patient? Do we want to? So in this trust, we've got a recommendation, a sort of type of protocol. We do give IV morphine in A&E, carefully titrated to effect. And we do not prescribe tramadol, we do not prescribe codeine. However, we do prescribe an opioid. And this is based on the fact that it's a patch, it's slow release, and it lasts for 7 days. Because in this hospital, the trauma wards are extremely busy and the nurse-patient ratio doesn't allow for Oromorph to be given regularly and on time. So the patch was a good way of providing a baseline pain relief that's effective for the patient. So we've done a fasciitis block, and yeah, that's it. And that's just a schematic view of it. The buprenorphine patch is an opioid, but it's a partial agonist, so the side effect profile is less. And it's probably this, I don't like to use the word safe and opioid together, but since it was introduced 4 years ago, I'm not aware of any respiratory depression or any adverse side effects associated with the Butrans patch. And it's 7 days, and they don't get a second patch after the 7 days. Good, so rats, remember rats. And in summary, remember the benefits of treating pain, remember functional pain assessments, the multimodal approach, non-pharmacological techniques, opioid stewardship, procedure-specific analgesia, and the rat approach. And that's it. Do you have any questions? Thank you very much for your attention. You do have a question. Brilliant. Hopefully I can answer it.
So for gabapentin,
Yes.
why does somebody start on 300 and then why do you start higher than?
So the side effect of gabapentin, the main one is sedation. Patients who are on gabapentin start to tolerate their side effect better. So if you're on it for a few days, the sedative side effects get better. It is influenced by the patient's renal function. So if they've got mild to moderate renal impairment, you can get accumulation of the drug. So what I would advocate for gabapentin is to start at 100 milligrams 3 times a day for anyone who's got renal impairment or the elderly, and you can titrate up. We used to, and there's still a few raised eyebrows by pharmacy, we used to give 1 dose of 300 on 1 day, 2 doses the second day, and then 3 doses the third day, and then continue at 300 milligrams 3 times a day. We don't do that now. We go straight 300 3 times a day. For a short period of time, it's really just for those patients who have had an operation. I can only talk surgically here. For those patients who have got opioid-resistant pain following an operation, just a short course of gabapentin to try and get some adjunct analgesic benefit. So 300 milligrams 3 times a day, but reduce it for elderly and really.
Just when you mentioned that central sensitization, do you just feeling that initial pain?
So central sensitization is when you get, so clinically, someone, what central sensitization provides the patient with is like things like allodynia, so you get an unpleasant sensation with a non-painful stimulus, and hyperalgesia, so you know, for a painful stimulus like a blood pressure cuff going up, it's unpleasant for a patient to have a blood pressure cuff go up. But people with hyperalgesia are screaming the place down when that blood pressure cuff goes up. Cannulas, they're not pleasant, are they? At the end of the day, it's still a needle going in through a skin, but you do get patients who are like, you know, they're screaming the place down with the cannula going in. They're the ones that are expressing hyperalgesia and this central sensitization. What makes so there's surgical reasons, so a very painful operation, crush injuries, pain over a long period of time. Those are the main things. And opioids for a long period of time can upregulate NMDA receptors. So pharmacological reasons as well.
Sorry, last question.
Sorry?
Just for like if renal dysfunction, if you've got like pyelonephritis or like stones and you're not sure if is it just paracetamol and then just work your way up?
So you've got to be a little bit careful, but I know that here they love PR diclofenac for stones, urology, pain, biliary colic. You've got to be a little bit careful because it can exaggerate renal dysfunction. So I'm not a great fan of anti-inflammatories and renal dysfunction, but yeah, it's a case-by-case basis, really. First line in this trust is naproxen and then ibuprofen. Voltarol it's the highest likelihood of causing gastritis, I think, so we don't really like that drug that much. Please feel to email me. I think my email address is on the front of the slide, and I'm on Twitter as well. DM me on Twitter and ask me a question there. Thank you. Thanks for your time.